Welcome to the Funnel Effect. Today, we are launching into a deep dive, really getting into the weeds on what might be the single highest stakes area in interventional cardiology. We're talking about the left main coronary artery, the LMCA. Our focus is a really foundational document, a roadmap, if you will, for using advanced imaging to guide treatment in this absolutely critical zone. We're analyzing the consensus statement from the European Bifurcation Club, the EBC. And just so you have the full citation, the source material we're distilling for you is titled Intravascular Ultrasound in the Evaluation and Treatment of Left Main Coronary Artery Disease, a consensus statement from the European Bifurcation Club. The authors are Gary S. Mintz, Terry Lefebvre, Jens F. Lassen, Luca Testa, Manuel Pan, Jag Singh, Goran Stankovic, and Adrian P. Banning. And this was published in Eurointervention back in 2018.
Yeah, and it's almost impossible to overstate just how vital the LMCA is. Think of it like, I don't know, the main water pipe supplying a huge city. If that gets blocked, well, the consequences are severe. Obstructive disease here, it just carries a particularly poor prognosis. And that's because of what it does. It usually supplies blood to, well, upwards of 75% of the entire left ventricle.
75%. Wow.
Yeah. So if that vessel gets compromised, the amount of heart muscle potentially lost downstream is just catastrophic.
And the big challenge, right, even now with all our modern tech, is figuring out just how bad the blockage is using standard angiography, the X-ray.
That's the core problem. Standard coronary angiography gives us that familiar picture, that X-ray image, but this consensus statement really hammers home its limitations, especially in this complex anatomy. Angiography, I mean, fundamentally, it's a two-dimensional shadow, a shadow graphic, as the paper calls it.
Just a silhouette of the dye.
Exactly. So you're only seeing that contrast flow. It's prone to all sorts of projection issues, like foreshortening, where things look shorter than they are. And it makes telling the difference between, say, eccentric plaque that's only on one side and just diffuse narrowing incredibly difficult.
Right.
And because LMCA disease is often diffuse, you frequently don't have a truly healthy section nearby to compare it to. So judging severity accurately becomes, well, it can be a high-stakes guess.
Okay, let's unpack this then. This is where intravascular ultrasound, IVUS, comes in.
Yeah.
It's positioned as the solution here.
It really is transformative in this context. Unlike angiography, IVUS is tomographic.
Tomographic meaning cross-sectional.
Precisely. It gives you true cross-sectional images. You can see the size of the lumen, the opening, and this is crucial. You see the vessel wall characteristics. You see the plaque itself.
You see the disease burden, the remodeling, things angiography just can't show.
Exactly. And that ability to see the plaque, the calcium, how the vessel has remodeled, that's key. And just quickly, for those thinking about other imaging like OCT, IVUS generally has better tissue penetration. That's an advantage in these often large, sometimes heavily calcified left main arteries.
Okay, so the EBC, seeing these angiography limits and the power of IVUS, isn't just suggesting it, they're recommending routine use, is that right?
That's exactly it. This document pulls together years of clinical work, registry data. It's a consolidation. Their goal is really to standardize the whole process, to give a definitive guide on the how and the when for using IVUS. By setting out these best practices for assessment, for optimizing the procedure, the mission is clear. Standardize the care, improve patient outcomes. It's a complex intervention, and this aims to make it safer, more effective.
Got it. So this deep dive is about understanding that standardization. Let's start with the basics then. Before we get into blockages and numbers, what does a normal LMCA look like? What governs its structure? Anything stand out from the sources on its predictability?
Well, what's fascinating is that the LMCA and how it splits into the LED and circumflex, it actually follows these predictable geometric rules from physics, actually, like fractal geometry and Murray's law, which basically links vessel size to blood flow efficiency. And IVUS data from lots of studies consistently backs this up. We know what normal looks like.
Okay, so they're expected dimensions.
Yes. For instance, the data cited suggests a normal or maybe just minimally diseased LMCA should have pretty large lumen cross-sectional area, or CSA, typically somewhere in the range of, say, 16 to 18 square millimeters.
That's quite large.
It is. And then if you look downstream, the two main branches, the left anterior descending, LAD, and the left circumflex, LCX, they each have smaller CSAs, generally around 10 square millimeters each. So having this solid baseline gives us something reliable to measure against when we suspect disease.
Right, we have this predictable starting point. But then, when atherosclerosis, the plaque buildup, starts, the body does something a bit counterintuitive, doesn't it? It tries to hide the disease initially. This idea of positive remodeling.
That's absolutely crucial. Glagoff's work really highlighted this. It's key to understanding why angiography can be so misleading early on. When plaque starts building up in the wall of the LMCA, the vessel often reacts by actually enlarging outwards. That's positive remodeling.
So the whole pipe gets bigger.
The total vessel area increases, yeah. And it does this to try and preserve the size of the lumen, the channel for blood flow, even as the plaque burden grows. So the disease is there, progressing, but the lumen might still look okay on an angiogram for a while.
So if the vessel enlarges to compensate,
Hmm.
how does the dangerous narrowing, the stenosis, actually happen then?
Well, it often comes from the opposite process, negative remodeling. That's where the vessel actually shrinks or constricts. This is pretty common in osteosclerosis that's narrowing right at the opening of a vessel. Could be the main LMCA ostium or the LAD or LCX ostium. And the sources point out that this negative remodeling, this shrinking, can cause dangerous narrowing sometimes, even without a huge amount of plaque right there. And there's even an anatomical link. Patients who naturally have anatomically shorter left main arteries seem to be more prone to these ostial narrowings, whereas those with longer LMCAs tend to develop blockages further down, closer to the bifurcation point.
This leads us perfectly into what you called a major aha moment from IVUS, debunking this idea that LMCA disease is often focal, just the tight little pinch point. Angiograms can make it look that way.
They really can. That visual impression of a neat focal lesion, it's highly misleading, especially at bifurcations. It is very rarely focal. There was a study by Oviedo and colleagues looked at 140 patients. It just laid bare how extensive and diffuse this disease usually is. They found plaque was continuous, like a sheet, stretching from the LMCA right into the proximal LAD in a staggering 90% of patients. 90%.
Wow.
And into the LCX in 66%, and critically, into both the LAD and LCX simultaneously in 62% of cases.
So when a cardiologist sees what looks like bad disease just at the tip of the left main, it's almost certainly this continuous sheet of atherosclerosis spreading way down into both main branches.
That's the reality IVUS reveals. It's like this sheet wrapping around the whole junction. But there's one consistent finding that's really important for treatment: the cortium. That's the sharp ridge of tissue dividing the flow between the LAD and LCX. That spot is almost always free of disease. Plaque tends to spare that sharp divider.
Okay, the Curian is spared. But why is understanding this diffuse, continuous nature of the plaque so critical for the person doing the procedure, the interventionalist?
It changes everything for planning. If you know the plaque is continuous, then trying to precisely place a stent right at the true opening of the LAD or LCX, based only on that 2D angiogram shadow, it's incredibly hard, and often it just doesn't work well.
Because you can't really see where the plaque ends.
Exactly. Angiography just doesn't give you the detail to see the true edges of the disease, and this explains why procedures guided only by angio often have suboptimal results. Operators might think they're treating a focal spot, but they're actually undersizing the stent or, crucially, failing to cover the entire disease length. That's what we call geographic miss.
Leaving diseased artery exposed at the stent edge.
Right. And that leads to problems down the line. Plus, think about the heart beating. The sources actually mention studies quantifying stent movement up to 5.5 millimeters between systole and diastole.
A bunch.
Yeah. So if you're already struggling with a 2D image of continuous plaque and the target is moving that much, relying on fixed landmarks is just asking for trouble. IVUS, giving that cross-section, helps take the guesswork out of finding those true disease margins.
Okay, that makes sense. So accurate IVUS imaging is key. But the LMCA isn't just a straight pipe, it's this complex junction. Getting a good IVUS reading must require some specific techniques. What are the must-dos the EBC highlights?
Absolutely. Technique is paramount. There are 3 really non-negotiable points for getting reliable images. First, when you're looking right at the LMCA ostium at the very beginning where it comes off the aorta, you absolutely must disengage the guiding catheter. Pull it back slightly.
Why is that so important?
Because if the tip of that guide catheter is still poking into the vessel, it can easily look like an ostial blockage on the IVUS image. You could mistake the catheter for disease and end up treating something that isn't real stenosis.
Okay, so disengage the guide. What's second?
Second is achieving coaxial alignment. You need to keep the IVUS catheter running straight and centered as it pulls back through the ostium. If it's entering at a sharp angle, kind of off-axis, it can distort the image shape and make your measurements inaccurate.
Straight alignment. Got it. And the third point tackles the bifurcation itself.
Yes. Given how complex the geometry is and how diffuse the plaque usually is, you just can't reliably look at an IVUS pullback from the LAD and guess what's happening in the LCX or the other way around. The consensus is crystal clear. You have to do pullbacks from both main branches from the LAD back into the LMCA and from the LCX back into the LMCA. That's the only way to get the complete picture of stenosis severity in both vessels.
That need for precision leads us to a really important rule for interpreting the images, specifically the minimum lumen area, or MLA, the idea that the smallest MLA is the most accurate. Can you explain why? It relates to an artifact, right?
Exactly. It addresses an artifact caused by those sharp angles at the bifurcation. Imagine trying to measure the inside of a round pipe. If you look straight down it, you see a perfect circle. But if you hold your measuring tool at a sharp angle, let's say the IVUS catheter is coming back from the LCX, which often branches off quite sharply, into the much wider LMCA, the cross-sectional image you get won't be a circle. It'll look stretched out, more like an oval.
Because you're slicing through it diagonally.
Precisely. That oblique cut by the IVUS beam creates a geometric artifact, and that artifact makes the minimum lumen area measurement look artificially large. It seems wider than it truly is.
So the reading could be misleadingly optimistic.
Correct. But here's the critical flip side. The physics of it mean the technique cannot create an artificially small MLA through this kind of geometric distortion. So when you do those mandatory pullbacks from both the LAD and the LCX, the absolute smallest MLA value you measure across those two complete pullbacks, that smallest number is guaranteed to be the most accurate, most reliable assessment of the true narrowest point. You have to trust the smallest MLA you find.
Okay, trust the smallest number. Now, let's get to the really crucial part. The numbers that decide if a patient needs intervention. Once we have that accurate MLA, what's the key anatomical threshold the EBC recommends for deciding, yes, this LMCA needs treatment?
For the typical patient population studied, mostly European and North American, the EBC consensus sets a pretty clear anatomical threshold. They recommend that an MLA cutoff of 6.0 square millimeters or less is the critical value.
6.0 millimeters squared.
Yes. An MLA at or below 6.0 millimeters squared generally indicates that the LMCA stenosis is significant enough that it should be treated with revascularization, either stenting or bypass surgery.
And this 6.0 number isn't just pulled out of thin air. It's based on outcome data.
Oh, absolutely. It's heavily grounded in clinical registry data, especially the ALIO registry. That study was quite revealing. They found that 96% of patients who had an MLA of 6.0 millimeters squared or greater actually had their treatment deferred, managed medically, and generally did well. Conversely, over 90% of those with an MLA below 6.0 millimeters squared went on to receive treatment.
But you mentioned some concerning edge cases within that data.
Right. The nuance is important. Patients who were deferred, so not treated invasively, but whose MLA was in that borderline zone between 5.0 and 6.0 millimeters squared, they actually had a poorer cardiac death-free survival rate, only 86%.
That's quite a drop.
It is, and it strongly supports the idea that 6.0 millimeters squared is a pretty reliable anatomical line in the sand to distinguish those who can likely be safely managed medically versus those who really need intervention.
And you mentioned earlier studies actually used a higher threshold, suggesting we're getting more precise over time.
That's right. Some earlier work, like the FASA study, used a larger cutoff, around 7.5 millimeters squared. They found patients deferred below that number had very high event rates. So it shows the value of IVUS guidance over time, but 6.0 millimeters squared is the current EBC-endorsed anatomical standard for making that treatment decision.
Okay, so that's the anatomical threshold. Let's contrast that with functional assessment using fractional flow reserve, or FR, which measures the pressure drop across the blockage. How do these IVUS MLA numbers actually correlate with FFR? Do they line up neatly with that 6.0 threshold?
Well, this is where it gets really interesting and, frankly, a bit complicated. The correlation isn't as straightforward as you might hope. Early studies, like one by Josti et al., did suggest a link. They found an MLA less than 5.9 millimeters squared seemed to predict a significantly abnormal FFR, less than 0.75 back then.
Okay, pretty close to 6.0.
Close, yes. But then the clinical standard for an abnormal FFR shifted slightly to less than or equal to 0.80. And when later larger IVUS studies looked at that FFR threshold, they consistently found the optimal MLA cutoff to predict functional significance was actually quite a bit lower than the EBC's anatomical 6.0 number.
Lower. How much lower?
Significantly lower. Studies by Kang et al. And Park et al. Both pegged the optimal IVUS cutoff to predict an FFR of 0.80 or or less at around 4.5 square millimeter.
4.5. That's a big difference from 6.0.
It's a huge difference. It implies that a lesion could have an MLA as low as, say, 4.6 millimeters squared, which looks anatomically quite significant but still be functionally okay, not causing a major pressure drop.
So functionally, the vessel could be tighter than the anatomical standards suggest before it needs fixing.
Based on these FFR correlation studies, yes. They also found other IVUS predictors for a low FFR, like a really high plaque burden specifically, over 77% of the vessel area filled with plaque or signs of plaque rupture, which dramatically increased the odds of functional significance.
Okay, this 1.5 square millimeter gap between the EBC's anatomical 6.0 and the functional correlation around 4.5, that seems really important. Why would the anatomical standard be set so much, well, more conservatively than the functional data might suggest?
This is a major point of discussion, and the evidence strongly points towards differences in patient ethnicity and baseline vessel size. The consensus document references work comparing patient groups. It showed that, on average, Asian patients tend to have naturally smaller left main coronary arteries compared to, say, white North American patients.
The smaller starting point.
Exactly. In one cohort mentioned, Asian patients had a mean baseline MLA around 5.2 millimeters squared, whereas the North American group averaged 6.2 millimeters squared.
Ah, okay. So if the whole vessel is smaller to begin with, then the absolute area measurement that causes a significant pressure drop would also be smaller.
Precisely that. If a 4.5 millimeter squared blockage in a smaller Asian LMCA causes the same functional problem as a 6.0 millimeter squared blockage in a larger European LMCA, then a single universal anatomical number doesn't quite fit everyone.
So the EBC's 6.0 is valid for the populations it was mainly derived from.
Right. It's validated for European North American cohorts, but this highlights a really critical global point. Maybe these absolute anatomical thresholds need some adjustment based on ethnicity or baseline vessel size. Or it argues for potentially relying more on functional assessment like FFR to confirm the need for treatment, especially if the IVUS MLA falls into that gray zone between 4.5 and 6.0 millimeters squared.
It's a really key nuance.
Okay.
Okay, so let's say the decision is made to intervene. The role of IVUS then shifts from diagnosis to actually guiding the procedure, right?
Yeah.
Planning the stenting. What are the key planning steps IVUS enables?
Absolutely. Once you decide to treat, IVUS becomes indispensable for planning. The EBC outlines 4 key areas. First is assessing the risk of side branch compromise. Since we're working at that Y junction, the left circumflex is always vulnerable when you stent the main vessel into the LAD.
So IVUS looks for warning signs.
Exactly. It can identify things like a vulnerable carina, sometimes called the eyebrow sign, which is basically a soft bulging plaque right near the LCX opening that looks like it could shift and block the side branch. Even more important is identifying calcium. Angiography is notoriously bad at showing the true extent and pattern of calcium. IVUS lets you see it clearly, measure its thickness, and critically measure the arc or circumference it covers.
And that matters because...
Because if you see a significant calcium arc, the paper suggests greater than 60 degrees on a longitudinal view, that's a strong, independent predictor, that the LCX ostium is very likely to get pinched or narrowed significantly after you deploy the main stent.
So that tells the operator they might need to prepare the vessel differently, like using atherectomy.
Precisely. It might dictate using rotational or orbital atherectomy before stenting to modify that calcium, making the stenting safer and more effective. That's predictive power angio just doesn't have.
Okay, risk assessment is step 1. Step 2 is about covering that diffuse disease we talked about earlier, getting the length right.
Yes, that's stent length determination. Avoiding geographic miss, leaving diseased plaque uncovered at the stent edges, is absolutely critical because that's a major cause of later failure, or edge restenosis. IVUS, with its automated pullback feature, lets the operator measure the exact length needed, millimeter by millimeter. You ensure the stent covers from a healthy proximal spot all the way down to the intended healthy distal landing zone, often deep into the LAD. This precision minimizes that risk of leaving disease behind.
Makes sense. Step 3 is choosing the right stent diameters, because the LMCA is much wider than the LAD.
Exactly. You have to size the stent appropriately for where it's going. You measure the diameter of a distal reference, usually the LAD, to pick the initial stent size. But then, crucially, you also measure the proximal reference size, the much wider LMCA. This confirms that the stent you've chosen can actually be safely expanded to match that larger LMCA diameter later on during the optimization phase. You need a stent that can accommodate both sizes.
Okay. And the final planning step involves a specific technique. POT.
Right. Planning for the proximal optimization technique, or POT. This is basically a non-negotiable step in modern LMCA stenting. The goal of POT is to take the stent, which you initially sized and deployed based on the smaller distal vessel, the LAD, and then fully flare out and extend its proximal portion to perfectly match the large diameter of the left main.
And IVUS guides the balloon choice for that.
Precisely. IVUS measures the exact diameter and the length of the LMCA segment involved near the bifurcation. This lets you choose a POT balloon that's big enough in diameter for the LMCA, often 5.0 millimeters or even larger, but also, crucially, short enough.
Why short?
Because if the POT balloon is too long, it could extend too far proximally, maybe damaging the aorta, or extend too far distally, potentially crushing or distorting the stent across the LCX opening. IVUS allows really accurate positioning and sizing for that POT balloon, ensuring the stent is fully open and pressed against the wall in the LMCA segment without causing collateral damage.
Got it. So 4 key planning steps. Now, in terms of the overall stenting strategy, does the EBC recommend a default approach for bifurcations like the LMCA? 1 stent or 2?
Yes, they do. The EBC generally favors a provisional approach as the default strategy for most bifurcations, and that includes the LMCA.
Provisional meaning you aim to use just 1 stent.
Correct. You aim for a single stent, usually placed from the LMCA into the LAD, crossing over the origin of the LCX. This is generally preferred because it's simpler and, if successful, tends to have better long-term outcomes with lower restenosis rates compared to routine 2-stat strategies. The typical provisional steps involve wiring both branches, LAD and LCX, deploying the stent into the LAD, sized to the LAD, and then performing POT. A critical point from the sources is that the stent used must be one that's known to tolerate high-pressure post-dilation to those large LMCA diameters, often over 5.0 or 5.5 millimeters. Not all stents are designed for that. And procedurally, POT should always be done before you try to rewire into the side branch, the LCX.
Okay, so provisional is the default goal. But sometimes that side branch, the LCX, gets compromised anyway, and you do need a second stent. How does IVUS help predict when the provisional approach is likely to fail, forcing a 2-stent solution?
This is another area where IVUS provides invaluable insight. That Kang et al. Study looked closely at this. They performed IVUS before and immediately after deploying the single crossover stent into the LAD. They found that, on average, the minimum lumen area right at the LCX ostium dropped dramatically after the main stent went in from about 5.4 millimeters squared down to just 4.0 millimeters squared.
Wow, that's a big pinch just from stenting the other vessel.
It is. But IVUS also revealed why. The main reason for that lumen loss wasn't new plaque getting squeezed into the opening or spasm. It was primarily due to carina shift.
Carina shift, meaning the divider moved.
Exactly. When the main stent in the LAD was expanded, it physically pushed the flow divider, that carina ridge, sideways, essentially partially blocking the entrance to the LCX. The stent acted like a snowplow, shifting the anatomy.
Okay, understanding that mechanism is key.
It is, because it allowed them to identify specific pre-procedural IVUS measurements that could predict when this carina shift would be severe enough to cause a functionally significant blockage in the LCX, either a very small final MLA or an FFR less than 0.80. The 2 main predictors for needing a second stent were: first, if the LCX ostium already had a small MLA before the procedure, specifically less than 3.7 millimeters squared, and second, if the plaque burden at the LCX ostium was high before the procedure, greater than 56%.
So if IVUS shows either of those features beforehand.
The risk of the provisional strategy compromising the LCX is much higher. It might lead the operator to consider a planned 2-stent strategy from the outset, potentially saving time and ensuring a better result, rather than trying provisional and having to bail out into a more complex 2-stent procedure later.
And if a second stent is needed, either planned or as a bailout, what are the required final steps according to the consensus?
If you commit to a 2-stent technique, whether it's a culotte, DK crush, T-stenting, whatever the operator chooses, the final optimization steps are critical. The consensus mandates a final kissing balloon inflation, using 2 balloons simultaneously in the LAD and LCX ostia, followed by one last, meticulous POT of the proximal LMCA segment. And then, of course, a final post-stenting IVUS run is essential to check the result, confirm good expansion and apposition everywhere.
Okay, IVUS guiding every single step. But the crucial question remains, does all this meticulous IVUS guidance actually translate into better long-term outcomes for patients? Does it save lives compared to just using angiography?
This is where the evidence becomes really powerful. The data strongly suggests it's not just a procedural refinement, it's closer to a standard of care for improving outcomes. A major meta-analysis, pooling data from 10 different studies involving thousands of patients, directly compared IVUS-guided versus angiography-guided LMCA stenting. The results were striking. IVUS guidance was associated with a significant reduction in the risk of all-cause mortality death from any reason by 40%.
40% reduction in mortality. That's huge.
It is. And even more specifically, the risk of cardiac death was reduced by 53%.
Over half. That's staggering. It really implies that angiography alone must be missing critical procedural issues that lead to these terrible long-term events.
That's exactly the implication. The benefits didn't stop at survival either. IVUS guidance also led to significantly lower rates of target lesion revascularization, TLR, meaning fewer patients needing repeat procedures on the treated area, and also fewer cases of definite or probable stent thrombosis, ST, which is a catastrophic complication.
And did they look specifically at the complex distal LMCA lesions?
Yes, a specific analysis focusing on those tricky distal bifurcation lesions confirmed the benefit. IVUS guidance reduced the combined rate of death, heart attack, MI, and TLR from 19% in the angio-guided group down to 11% in the IVUS-guided group. The message is pretty clear. If you're intervening on the LMCA, especially the distal part, IVUS should really be part of the procedure.
Let's drill down into why these outcomes are so much better. What's the single biggest procedural flaw that IVUS helps prevent? The one most strongly linked to bad outcomes like restenosis or MAE, major adverse cardiac events.
Without a doubt, the primary culprit for long-term failure for both in-stent restenosis, ISR, and overall MACE is underexpansion of the stent.
Meaning the stent isn't opened up enough?
Exactly. If the stent isn't fully expanded and pushed firmly against the vessel wall, it creates areas of disturbed blood flow. It can be a trigger for clot formation, thrombosis, and it promotes the growth of scar tissue or neointima inside the stent, leading to re-narrowing. That Kang et al. Study, again, provides definitive data here. They followed 403 patients after LMCA stenting. First, they confirmed that ISR rates were much higher when 2 stents were used, 25.4%, compared to a successful single-stent provisional approach, 6.3%. That just highlights the inherent challenges in the more complex strategies. But crucially, they used the final IVUS measurements to define exactly what underexpansion means in the LMCA context. They established specific minimal stent area, MSA targets that must be achieved at different locations to minimize the risk of restenosis.
Okay, these MSA numbers sound critical for operators. Can you list those specific benchmarks for adequate expansion? Where do you need to measure and what are the minimum acceptable areas?
Yes, these are the geometric goals based on long-term follow-up. Failing to meet even one of these significantly increases risk. The 4 key locations and their minimum MSA targets are: first, in the main LMCA segment, proximal to the bifurcation point, technically, proximal to the polygon of confluence, POC, the final MSA needs to be at least 8.2 square millimeters.
8.2 proximal to the bifurcation.
Second, right at the POC itself, that triangular area just above the LADLCX split, the target is 7.2 square millimeters.
7.2 at the POC.
Third, at the ostium of the LAD, the opening into the LAD stent, it needs to be at least 6.3 square millimeters.
6.3 ostial LAD.
And finally, at the ostium of the LCX, whether it's stented or just jailed by the crossover stent, the minimum acceptable area is 5.0 ostial LCX.
5.0 ostial LCX, so 8.2, 7.2, 6.3, and 5.0. An angiogram could look perfect, wide open.
Absolutely. The angio might look beautiful, but if the final IVUS shows, say, only 7.0 millimeters squared in the proximal LMCA instead of the required 8.2, that patient has a structurally suboptimal result. They are carrying a significantly higher risk of future problems, despite the pleasing angiographic appearance.
And how common is this problem of underexpansion? Is it rare or?
It's surprisingly common. That same Kang study found that at least one of these critical MSA targets was not met in 33.8% of patients, over a third.
A third of patients left with an underexpanded stent segment.
Yes, and the clinical impact was stark. Patients with any underexpansion had a significantly lower MACE-free survival rate at 2 years, only 90% compared to 98% for those whose stents met all the MSA criteria. Underexpansion was identified as an independent predictor for MAE with an adjusted hazard ratio of 5.56. That means, all else being equal, leaving an underexpanded segment multiplied the patient's risk in a major adverse event by more than 5 times. Relying only on angio means operators are likely missing this routinely.
Wow. Okay, besides underexpansion, what other procedural risks or issues does IVUS help identify and manage?
Well, it's key for spotting that geographic miss we talked about, which often leads to edge restenosis. IVUS studies found a threshold for the lumen area right at the distal stent edge. If it was less than 4.8 millimeters squared, the risk of edge restenosis went up. This reinforces needing that accurate length measurement beforehand. IVUS also helps clarify some things maybe we don't need to worry about quite as much. For instance, some degree of acute stent malapposition where the stent struts aren't perfectly touching the wall right after deployment, specifically at the LMCA ostium, didn't seem to correlate with higher rates of restenosis there later on.
So a little space at the very top might be okay.
It seems so. Similarly, leaving a very small segment of the LMCA ostium itself unstented, maybe 1 or 2 millimeters, also wasn't generally associated with a higher risk of ostial restenosis, provided the main body of the stent was well deployed and expanded.
But there's one more mechanical issue IVUS can detect that's definitely bad news. Stent damage.
Yes, longitudinal stent deformation. This is where the stent structure itself gets compressed or stretched lengthwise, often due to friction from catheters or aggressive ballooning near the stent edge. This was actually seen in about 8.3% of stented LMCA lesions in one study. And even if it didn't immediately cause the MSA to drop below those critical thresholds, this deformation was strongly linked to worse outcomes down the road specifically, more LMCA-related heart attacks and repeat procedures at 3 years.
And IVUS is the only way to really diagnose that structural damage.
Pretty much. It gives you that cross-sectional and longitudinal view to see if the stent structure is intact. If deformation is seen, it usually prompts immediate action, like re-expanding with a high-pressure balloon to try and restore the proper geometry.
Okay, let's try and pull all this together. This EBC consensus essentially positions IVUS not just as an adjunct, but as a mandatory guide through the entire LMCA intervention process, covering 4 key roles.
That's a great way to summarize it. Yes, 4 key roles. First, diagnosis. Using those MLA cutoffs like the 6.0 millimeters squared for European cohorts, acknowledging the ethnic variations to help decide if revascularization is truly needed, going beyond the angiogram. Second, strategy. IVUS findings, like that pre-procedural LCX ostial MLA or plaque burden, critically inform the choice between the default 1-stent provisional approach and a planned 2-stent strategy.
Third, accurate sizing. Getting the stent diameter and, crucially, the length right, using those IVUS measurements to avoid geographic miss and ensure the stent can handle the size transition from LAD to LMCA.
And fourth, absolutely vital, optimization. Using IVUS post-stenting to ensure those minimal stent area targets the 8.2, 7.2, 6.3, 5.0 are met, confirming good apposition, diagnosing any deformation, and ultimately guaranteeing the best possible long-term result.
The evidence seems compelling.
It really is. The takeaway for you, for anyone involved in these procedures, is that while we might lack huge, definitive, randomized controlled trials comparing IVUS versus angio guidance specifically for LMCA, they are very hard to do well. The consistency and strength of the data from large registries and these meta-analyses are overwhelming. That dramatic 40% reduction in all-cause mortality, the 53% reduction in cardiac death, it provides very strong support for IVUS guidance being superior to relying on angiography alone in this high-risk setting.
The real power of this consensus document seems to be translating all that complex data into clear, actionable steps for clinicians. But, as we discussed, that whole issue around ethnicity, vessel size, and the discrepancy between anatomical, like 6.2 millimeters squared, and functional, around 4.5 millimeters squared, correlating with FFR thresholds, it leaves us with a really interesting, maybe provocative final thought. If we know baseline LMCA size varies, and the MLA needed to cause functional significance also varies, should we, as a global cardiology community, continue to rely heavily on standardized geometric thresholds like the EBC's 6.0 millimeters squared, even if they're based on solid data from specific populations? Or, looking forward, is the future perhaps more about individualized assessment? Maybe leaning more towards functional criteria using FFR, or developing ethnicity-adjusted anatomical cutoffs to ensure we're making the absolute best, most personalized treatment decisions for every single patient worldwide, even if it adds a layer of complexity. Something definitely worth thinking about. Thank you for watching The Funnel Effect.